Welcome back to Merit Laboratory Partners video training series on pharmacogenetic testing. This is part 2. In the last video, we had just touched upon this notion of personalized medicine. I want to define that a little more clearly. Personalized medicine is a medical model that uses molecular-based testing to customize each patient's treatment. And obviously, pharmacogenetic testing is a good example of how we put this into practice. Now, at its very best, I would argue that personalized medicine can improve outcomes and reduce adverse events. And again, that's by selecting the most appropriate drug for a certain patient based on his or her genetics and avoiding drugs that a given patient shouldn't have. Speaking of adverse drug reactions, these are a major problem in this country and throughout the world. In the U.S. alone, there are over 2 million serious adverse drug reactions a year, from which there are at least 100,000 deaths. And some people think the numbers are actually quite a bit higher than this. In any case, ADRs are considered to be something like the 4th, maybe the 5th leading cause of death in the United States. And obviously, if we can do genetic testing and somehow prevent even 5% of these, that's going to be a huge improvement. Just a few of the other benefits of pharmacogenetic testing. Here's another one, shorter times for finding the most effective drugs. If we can eliminate those drugs that an individual can't metabolize, right, we don't even try to give those to the patient, that's going to get us to an effective drug treatment much more quickly. Reduce costs, because again, we're not wasting time and money trying to find the right drug for a patient. Those, I think, are really compelling reasons that you could provide to a physician. I want to mention our current PGX panel because there are often questions about what genes exactly are you testing. Here's the full list. There's 16 genes. Now on the left, these are those cytochrome P450 genes that I mentioned. These genes are primarily responsible for metabolizing drugs, while on the right, we have a list of 9 other genes with various functions. Some of these are drug transporters, some are drug targets, and other genes simply inform us on risk factors for particular conditions, and I'll be talking about those more in just a minute. Once the laboratory has tested each patient for these 16 genes, we then present the physician with a report that's pretty easy to understand, and it consists of a set of recommendations that, in the spirit of personalized medicine, are tailored to the patient's genetic makeup. Here are the things that the report includes. A list of the patient's current meds, along with any specific warnings about them. That's assuming that the original requisition includes those meds. Other medications that may be affected, and right now for our medical management panel, which is the full panel covering all 16 genes, we report on well over 100 different drugs. We provide dosing guidance for some meds, although not all. And finally, we report the phenotypes for each of the genes tested. And this is especially important for all of the cytochrome P450 genes, where we tell you this patient is a rapid metabolizer for this gene, but a slow metabolizer for that gene. We also report on several risk factors, and this is included with our medical management or total panel. And these are 3 conditions that the patient can be genetically predisposed to and that are related to the field of cardiology. The 3 conditions are hyperhomocystinemia, hyperlipidemia, and thrombosis. Well, let's take a look at some of the reporting that we offer. I'll show you this on a drug-by-drug basis because that's kind of how we break it down. So here's an example where we're reporting on atorvastatin, also known as Lipitor. We provide the phenotype for this gene. In this case, the patient is an intermediate transporter. In other words, they're able to transport that drug out of the bloodstream, not quite at a normal rate, but not what we would consider to be a poor rate. And the evidence level for the guidance that we're providing is informative. Let's talk about what that means, because it's really important to know how to distinguish what we would consider to be very confident advice versus not so confident advice. If a particular piece of information we're providing is considered actionable, what that means is that there's a lot of evidence that backs up the recommendation. So experts in pharmacogenetics have said, yes, the relationship between this particular mutation or this particular genotype and this piece of advice is very strong. And so when something is actionable, clinicians should feel strongly about making that recommendation. Now, in some cases, the evidence for a particular recommendation isn't as strong. Maybe the numbers in a given report, the number of patients that were tested, not really high enough to say, yes, this is definitely rock solid. Or in some cases, evidence may actually be contradictory from one study to another. And so clinicians should consider using these recommendations as starting points, but they're not gospel. Well, getting back to each of the drugs, you'll notice that to the left of the drug name, there's always a flag. And in this case, we're getting a caution flag, meaning we should probably pay attention to this drug. There could be something concerning. Let's take a look at what each of the various flags means. So if there is a red flag, that means that because of the patient's genotype, the medication listed could either have reduced efficacy or increased toxicity. And of course, that will be explained in the lines below the drug name. In these cases, whenever there's a red flag, the physician should consider alternatives. If there's a yellow caution flag, that means that the physician may need to adjust the dosage or simply use increased vigilance. In other words, they should monitor what's going on with the patient whenever they prescribe that drug. And finally, if there's a green check mark, that means based strictly on genotype, the physician can prescribe the medication at normal dosages. Let's look at some examples of where there may be an ineffective drug for a given patient. So let's say that the particular patient we're talking about has a mutation that causes a decrease in the activity of CYP2C19. That's the gene that is responsible for converting clopidogrel, also known as Plavix, from its prodrug into its active form. Well, adequate blood levels of the active drug simply can't be achieved whenever a person has a mutation that decreases CYP2C19's activity. And so the drug has a reduced ability to prevent heart attack, stroke, or death from some other cardiovascular event. So in the report next to clopidogrel, we see where this patient is an intermediate metabolizer. And as a result, the physician should consider prescribing an alternative antiplatelet therapy. Statin-related myopathy is another risk that we report on, and that's due to this one gene, SLCO1B1, which is a transporter. And if a patient has a specific variation in that gene, well, that could potentially cause problems. And you see here, next to simvastatin, we have a red flag. And there is, in fact, an intermediate myopathy risk with this patient. The physician really should consider avoiding prescribing simvastatin to this person. The final example I want to cover is one in which there is a potential toxicity. Here's a patient who has a mutation in CYP2D6, and it's a mutation that actually increases the gene's activity, resulting in the so-called rapid metabolizer phenotype. People with this phenotype rapidly convert inactive prodrugs into their active metabolites, and so they basically flood their system with active drug. This can lead to toxicity, and tramadol is one example in which that can happen. So you can see this patient increased response because of the rapid metabolizer phenotype. As a result, they're at high risk of toxicity. This doesn't mean that the patient can't take tramadol. You can see that we do make a recommendation to the physician to try a reduced dose to about 1/3 of normal. And they need to carefully monitor that patient as they titrate the drug. And that's it for the introduction to pharmacogenetic testing. I hope you'll join me for future videos when we cover more in-depth information about reporting and we talk about improvements that are coming to the testing itself. Please join me then.